Welcome to Obesity Chronicles, a novel perspective. My name is Robert Kushner, and I'm a professor of medicine and medical education at Northwestern University Feinberg School of Medicine and director of the Center for Lifestyle Medicine at Northwestern Medicine in Chicago. This program is intended for healthcare professionals. The information presented in this podcast is aligned with the views and opinions of the speakers and is sponsored by Novo Nordisk. The speakers have been compensated by Novo Nordisk for their participation in this program. This podcast is not to be used as medical advice and is intended for educational purposes only. It is not approved for continuing medical education credits. In today's podcast titled Obesity, a Choice or a Disease, we will explore whether obesity is a disease or a lack of willpower and whether it is realistic to expect people to overcome obesity on their own. I am pleased to be joined today by two esteemed colleagues, Lou Aroney and Jamie Ard. Lou, would you please introduce yourself to our audience?
Thanks so much, Bob. I'm a professor of metabolic research at Weill Cornell Medicine in New York City. I'm also the director of the Comprehensive Weight Control Center in the Division of Diabetes, Endocrinology, and Metabolism here at Weill Cornell.
Thanks, Lou. Jamie?
Hi, I'm Jamie Ard. I am a professor of epidemiology and prevention at Wake Forest School of Medicine, and I co-direct the Wake Forest Baptist Health Weight Management Center and lead our medical weight management program.
Thank you both for joining me. Obesity is a prevalent epidemic in the United States and is associated with an increased risk of several non-communicable diseases, such as type 2 diabetes and heart disease, among others. We often don't think about the economic burden of obesity, but it is costing our country a tremendous amount of money. According to data from the Medical Expenditure Panel Survey in 2016, chronic diseases due to obesity accounted for 9.3% of the U.S. gross domestic product. Data from 2001 to 2016 Medical Expenditure Panel Survey estimated that the cost of medical expenditure for individuals suffering from obesity was a staggering $260 billion in 2016. And according to the 2023 World Obesity Atlas, by 2030, the healthcare impact of both overweight and obesity is projected to reach $411 billion. The epidemic rates are continuing to climb, and it is projected that by 2030, approximately half of all adults in the United States will have obesity. Lou, can you please speak to this rising problem of obesity?
Sure, Bob. Obesity rates have been increasing at an alarming rate for decades, and that trend is expected to continue. Based on a predictive analysis of adult BMI data from over 6 million adults in the Behavioral Risk Factor Surveillance System from 1993 to 94 and 1999 to 2016, it's projected that by 2030, nearly half of all adults, 48.9%, will have moderate obesity, defined as a BMI of 30 to less than 35 kilograms per meter squared. And nearly a quarter of all adults, 24.2%, will have severe obesity, defined as a BMI greater than or equal to 35 kilograms per meter squared. And what is worrying about this trend is that there is no sign of decline. While overweight rates have remained stable or even declined, obesity and severe obesity rates are increasing rapidly. This suggests there may be some kind of physiologic factor driving the rise in obesity. I see this trend in my own practice. The number of people coming to see me for obesity-related complications is overwhelming. We can't keep up with the demand. There are just too many patients with this problem. Another concerning trend is that we're also seeing obesity in younger and younger people. Not only are young people gaining weight and living with obesity, but they're also developing obesity-related complications at younger ages. For example, we're seeing younger adults develop type 2 diabetes and cardiovascular disease.
So we just talked about the staggering economic cost of obesity, but now let's talk about the impact of obesity. Jamie, can you speak on the potential weight-related consequences of obesity?
Sure, Bob. The number of risk and consequences of obesity is significant and far reaching. These consequences can affect all body systems, from psychological to mechanical to cardiometabolic. Health complications associated with obesity include hypertension, dyslipidemia, and various types of cancers, among many other diseases. However, one of the most serious complications of obesity is cardiovascular disease, or CVD. In 2020, CVD was the number one killer of people in general, but people with obesity have an even greater risk of developing CVD. In particular, obesity is a major risk factor for cardiometabolic multimorbidity, which is the co-occurrence of two or more chronic cardiometabolic diseases such as type 2 diabetes, cardiovascular disease, and stroke. A collaboration of 91 cohort studies showed that cardiometabolic multimorbidity was a serious condition that was associated with a risk of death, which was substantially greater than that for each of the diseases on their own. In fact, I found a study that helps to illustrate this point. This study, which was a pooled analysis of individual participant data from 16 prospective cohort studies from the US and Europe that included 120,813 adults aged 35 years, found that after adjusting for sociodemographic and lifestyle factors relative to individuals with a healthy BMI, the risk for cardiometabolic multimorbidity was increased in people with overweight by twofold. This risk increased by 4.5-fold in people with obesity with a BMI of 30 to 34.9, and 14.5-fold in people with severe obesity with a BMI of 35 or higher. Overall, the risk rose 1.9-fold for each 5 kilograms per meter squared increase in BMI. And this is also what we observe in our practice, where we often see patients who have developed multiple weight-related complications as a result of their obesity. They may be taking multiple medications to treat conditions such as hypertension, dyslipidemia, and type 2 diabetes. The number of conditions may increase over time, especially as people age and start living with moderate or severe obesity. We often think about how much better it would have been if we are dealing with these patients earlier, before their obesity had progressed. If we had intervened earlier, we might have been able to prevent the progressive weight gain and perhaps improve symptoms related to certain weight-related conditions. It is important for us to understand that obesity is a chronic disease that can lead to progressive weight gain over the course of a person's life. For example, another study that looked at nearly 4,000 non-Hispanic white participants using NHANES data from 2003 to 2010 estimated that obesity was associated with a significant reduction in life expectancy from diabetes and cardiovascular disease, regardless of age or gender. This reduction was seen in people with a BMI of 30 to 35 and is even greater in people with a BMI of 35 or higher. And that reduction in years of life is something that is, as I would be willing to bet, is important to everyone. So obesity can create this ultimate cost of decreased years of life. The study also found that the effect of excess weight on healthy life years lost was 2 to 4 times higher than the effect on total years of life lost. This means that obesity not only shortens life expectancy, but it can also reduce the number of healthy years that people live, highlighting the importance of preventing obesity, especially in younger people. Because data shows that obesity may shorten life expectancy, it is important to address weight early.
Thanks, Jamie. We have discussed the rising epidemic of obesity and the associated healthcare costs. This is not just a matter of people getting larger, but also of the health implications of obesity. Jamie did a great job of reviewing this, but let's dig a little deeper now. What are the underlying causes of this epidemic? Is it a lack of willpower, a lack of decision-making, a problem of personal responsibility? And I hate to say it, could it be laziness? Lou, what do we really know about the potential causes of the obesity epidemic?
Well, Bob, some people may be genetically predisposed to develop abnormal accumulation of fat in the body in a so-called obesogenic environment. This can make people more susceptible to have obesity if they're exposed to environmental factors that promote weight gain, such as an abundance of unhealthy food and a lack of physical activity. The worldwide prevalence of adult obesity has nearly tripled since the 1960s due to the widespread presence of an obesogenic environment. These factors can include the increasing availability of ultra-processed foods and beverages, the lack of opportunities for physical activity, the decline in sleep, and some evidence suggests added stress. Also, as people eat high-fat foods, data suggests that these foods may cause an initial rise in inflammatory markers. One hypothesis is that overeating can cause inflammation in the hypothalamus, which is a part of the brain that regulates appetite and metabolism. It's possible that this inflammation could affect the structure and function of the neurons in the hypothalamus that can drive the return of body weight to its original weight that is observed in patients with obesity. But diet-induced hypothalamic inflammation may be just one part of a more complex process that leads to obesity, and data supporting a direct role of hypothalamic inflammation in causing weight gain is mixed. Thus, more research is needed.
Thanks, Lou. Jamie, what are your thoughts on the causes of the obesity epidemic?
Bob, I too agree with Lou and tend to frame obesity as a complex interaction between our genes and our environment. We live in an obesogenic environment, which means that it's easier to gain weight and difficult to lose weight. However, some people are more exposed to this obesogenic environment than others. If you live in a neighborhood with easy access to fast food, limited areas for exercise, and high levels of stress, and you work a third shift job, you're more likely to have a poor response to this obesogenic environment, potentially leading to dysregulation of body weight and weight gain. On the other hand, if you live in a neighborhood with healthy food options, safe places to exercise, and lower levels of stress, and you have a job that allows you to spend time being physically active and preparing your own meals, your exposure to this obesogenic environment is somewhat buffered. And so, when you combine the obesogenic environment with our individual genetic predisposition and the tendencies that come as a result of that genetic predisposition, it can become a challenge. For example, because of my genetics, my signals for satiety may be very different from yours in terms of their strength or the point at which I feel full. When you add all of these different factors together, it creates the ultimate phenotype or physical appearance that we end up seeing. When you also factor in neuronal inflammation and all of the other factors that Lou talked about, you start to see a complex picture of how we get to the body size that we get to and the distribution of that body fat.
I agree with Lou that hypothalamic inflammation is an emerging hypothesis. Does the environment affect us biologically along with our genetic predisposition? It is possible that our environment is starting to affect our weight since our gene pool has not changed in the last 50 or 60 years. Ultra-processed foods, along with other things, may be biologically affecting how we sense appetite and body weight regulation. So, Lou and Jamie, we're starting to better understand how environmental factors interact with genetics and biology to lead to this epidemic. The data are clear, but public opinion hasn't yet entirely caught up to the reality that obesity is a disease and needs to be treated in the same manner as other chronic diseases, like hypertension and dyslipidemia. This is true not only among the public, but also among clinicians. Why is this?
Many clinicians do not accept obesity as a disease because they have not heard experts like us explain the complex factors that contribute to it. However, once they hear us talk about the disease, it would be difficult for them not to accept that obesity is a chronic disease. When I speak at obesity conferences, I often ask my audience, why don't you guys lose weight? If you think it's so easy, why don't you just lose weight? I usually get a chuckle because I'm looking out at an audience of people, some of whom are struggling with weight management themselves. I point out that if losing weight were easy, I would not have a job.
I think that although many clinicians agree that obesity is a disease, I don't think that changes how they think about managing it. They still think of it as a disease that should be treated solely with lifestyle intervention. When a patient comes in with a blood pressure of 160 over 100, we jump all over that and say that along with lifestyle interventions, we may need to consider pharmacotherapy as well to achieve the target blood pressure of less than 120 over 80. However, in the space of obesity, there's a different level of urgency. We sometimes need to tell ourselves that lifestyle intervention alone may not always be effective. If the patient is not responding, we cannot simply continue recommending the same thing. We need to be willing to adjust our approach and consider a more comprehensive treatment plan. For example, if I saw a patient with a BMI of 29 and no complications, and they said they had recently gained 10 pounds in the past year despite trying lifestyle intervention, I would say that we have a problem. We need to do something to help them lose weight. I would still prescribe lifestyle intervention, but I would follow up quickly to see if they are losing weight. If not, I would move on to another approach in addition to lifestyle therapy as appropriate. I think most people ignore this early warning sign and wait until the BMI gets to 35 or higher before they do anything. By then, it's much harder to manage their weight.
My point of view is that obesity is a multifactorial, multifaceted disease that is not adequately covered in medical school or residency training. As a result, many clinicians do not have a good understanding of the physiology and pathophysiology of obesity. When clinicians do see patients with obesity, they're often focusing on treating the acute problems or weight-related comorbidities that the patient presents with, such as type 2 diabetes, hypertension, and knee osteoarthritis. And there's a tendency to quickly treat these symptoms that we now think are associated with obesity. If you asked any clinician if they think obesity is a serious problem, they would almost certainly say yes. They would also likely say that they think more time should be spent managing obesity. However, if you ask them if they consider obesity a disease itself, the answer would not be as clear. Many clinicians believe that obesity is a gateway to developing other medical problems, but they don't see it as a disease itself. Lou, since we are on the topic of medical education, what are your thoughts on how medical schools are preparing students to manage patients with obesity?
Well, Bob, we're not doing a good job at all. And as clinicians, we need to do better. We need to lead the charge to create a more inclusive healthcare system and to train our peers and our patients about obesity as a disease. One key barrier to this, as you've already mentioned, is the lack of training in medical school on obesity. A 2018 online survey of deans and curriculum staff from 40 U.S. medical schools found that 1/3 of respondents had no obesity education program in place and no plans to develop one. On average, a total of 10 hours was reported as being dedicated to obesity education. Only 10% of respondents felt that their students were very prepared to manage patients with obesity. This is not good enough. We need to do a much better job of training future clinicians about obesity. In fact, Bob and I reviewed this at the National Board of Medical Examiners, and Bob led the effort to review the U.S. medical licensing exam. We found that while there were many questions about obesity-related complications, such as cardiovascular disease, hypertension, and fatty liver disease, we did not find any questions that specifically addressed obesity. We understand that there are many important topics to cover in the medical school curriculum, and that everyone is vying for their content to be included. However, if obesity is included as a topic on the licensing exam, it can provide a strong incentive for medical schools to prioritize obesity education.
That's right, Lou. We spent a day and a half at the National Board of Medical Examiners, the organization that tests medical school students who are earning a license in medicine. We found that the vast majority of questions were testing on complications of obesity, not on the pathophysiology, epidemiology, genetics, or treatment of obesity. We went to the top because students are always asking us, is this going to be on the exam? We felt that if obesity was covered in the exam, it would be a greater impetus for students to pay more attention to the material that's being taught and have curriculum spend more time on obesity. In fact, I actually volunteered the entire year after that to write examination questions for the USMLE. I believe it was an important wake-up call. We also pointed out that they were not using patient-first language. For example, they would say an obese patient instead of a patient with obesity. We made a whole list of recommendations, and I believe that our study was a landmark moment in the effort to improve medical education.
In terms of medical education, like undergraduate medical education, medical schools residency, even fellowships, there's still a long way to go. I would like to reiterate the point that Lou made earlier that there's a lot of information that people have to cover in medical school, and it's hard to fit everything in. We have to constantly argue for why our information needs to be part of the curriculum. And if we include ours, what's not going to be included? So, as obesity educators, we are constantly negotiating for that. In the best case scenario, like in our school, the best we can do is create elective courses for students who are interested in obesity medicine, so our students can get more in-depth information. But that's the best we can get right now.
And this may be one of the reasons obesity is underdiagnosed and undertreated, and there is data to back this up. One study evaluated electronic health record databases with more than 2 million adult patients from U.S. primary care. It found that 72% of patients with a BMI of 30 kilograms per meter squared or greater were not documented as having been diagnosed with obesity. The number is very concerning, and it's not just that obesity is underdiagnosed, it's also undertreated. Another study known as the ACTION study, which surveyed 3,008 adults with obesity with a self-reported BMI of greater than or equal to 30, 606 healthcare professionals or HCPs, and 153 employer representatives to examine obesity-related perception, attitudes, and behaviors, found that only 24% of patients with obesity who discussed their weight with a healthcare professional in the past 5 years reported that follow-up care was scheduled. This too is worrisome. It seems like there's a big problem with the way obesity is being managed. Lou, why do you think that some HCPs are not diagnosing or treating obesity?
For a couple of reasons. Many HCPs have believed that there was not anything that could be done about obesity, so they focused on treating the problems that they could treat, as you mentioned, Bob, such as hypertension and diabetes. They didn't want to waste their time on a problem that they thought they couldn't treat. It could also be considered embarrassing to bring up weight. HCPs are trained to ask permission before discussing a patient's weight, but they don't have to ask permission to discuss other problems, such as diabetes or blood pressure. Your doctor will clobber you over the head if you have hypertension. Don't you know you could have a stroke with this hypertension? So HCPs just don't diagnose or treat obesity because they may feel uncomfortable with it and because they may not be really sure about what they could do.
I think obesity is unlike any other medical problem that we see. There isn't the same level of stigma and discrimination bias with individuals living with hypertension or diabetes. It's seen with obesity. Obesity has been described as the last acceptable prejudice in our society. Obesity is very personal, particularly in this day and age of body positivity at every size. Patients may feel their autonomy is being violated when they are repeatedly asked about their weight, especially if they've been told in the past to just move more and eat less. This can lead to internalized weight bias, where patients believe that their weight is the only thing that matters and that they are not capable of losing weight. As clinicians, we need to recognize the bias and stigma surrounding weight, and we need to be respectful of our patients' experiences. In particular, we can show respect by acknowledging that talking about weight is a personal matter. We can say something like, I would like to talk to you about your weight, but I understand that this is a personal topic. Is this something you are comfortable discussing? I talk to medical students all the time, and I ask them, when you see someone with diabetes or hypertension or fatty liver disease, do you ask permission to talk about that? Most say no. Well, so why is obesity different? I don't argue that we should ask for permission. I argue why we should with obesity for the reasons I just discussed. I make that very clear to medical students. If you take the 5 A's, which is a framework we use for patient counseling, we've adopted the first A to ask rather than assess because we need to get this conversation started about obesity. Jamie, can you share some of your thoughts on obesity stigma?
I think the way clinicians approach obesity with patients is often stigmatizing and underpinned by bias. I think as a result, they realize or learn that they don't do this well, so they just don't bring it up. It makes them uncomfortable and it makes the patient uncomfortable. So why bother with that when I can very competently treat the person's type 2 diabetes and keep myself moving on and not create this sense of discomfort? I usually recommend asking patients, do you have any issues related to your weight? This is an opening question that gives you a sense of how they're thinking or prioritizing the impact of their weight on their life. They may or may not understand that their blood sugar or blood pressure may be related to their weight, but they might really know that their knees weren't hurting a few years ago and now they are. And then I can always follow up with something like, are you interested in learning more about things that might help you not have your knees hurt and be part of a weight management strategy? A lot of people get stuck because they're offered solutions that they've heard before, like eat less and move more. They've heard that a million times and tried 100 times, and they're interested in something that's much more comprehensive. So we need to be more creative in individualizing our approach to weight management. We need to meet patients where they are and offer them support they need in order to succeed.
Jamie, what are the different options available for people with obesity who are struggling to manage their weight? What is the recommended approach to weight management by most national medical societies?
Multiple national medical societies from diverse fields, including obesity, cardiology, endocrinology, pediatrics, and others, have emphasized the need for a holistic, comprehensive weight management approach to managing obesity that includes comprehensive lifestyle interventions, pharmacotherapy in addition to lifestyle interventions, and surgery as needed for appropriate patients. Lifestyle modifications such as healthy eating and regular physical activity are the foundation of any weight management plan. However, for many people with obesity, lifestyle modifications alone may not be enough to achieve and manage their weight. And weight management does not always end there. They all support the use for pharmacotherapy along with lifestyle interventions for chronic weight management for appropriate patients. Guidelines also recommend surgery, which is a proven option for more severe obesity or obesity associated with lots of complications. It's important to note that weight management is a long term process that requires commitment and support. A holistic and comprehensive weight management plan should be tailored to the individual's needs and weight goals.
So we have all these societies recommending the use of holistic, comprehensive weight management interventions for appropriate patients. But it's also important to understand when to leverage different treatment options for your patients based on their BMI. Jamie, can you expand on that?
So, to illustrate a comprehensive treatment plan based on BMI, let's use the American Association of Clinical Endocrinology / American College of Endocrinology guidelines as an example. A combination of lifestyle modifications such as eating a reduced calorie, healthy diet, exercising more, and getting behavioral therapy as well as pharmacotherapy can be appropriate for certain patients with a BMI of 30 or more, or a BMI of 27 or more with one or more weight related complications. Pharmacotherapy, along with lifestyle therapy, may help patients achieve greater weight loss and weight loss maintenance than lifestyle therapy alone in patients with a BMI greater than or equal to 27 with complications, or in patients with a BMI greater than or equal to 30. For patients with severe obesity with a BMI of 35 or more, bariatric surgery may also be considered. So, we should always consider the severity of obesity when deciding which treatment options to offer our patients. If a patient has tried multiple times to lose weight using evidence based strategies, then I don't think it's necessary for them to repeat that effort again and again before you move on to considering additional medical interventions. Explaining how the new treatment plan will be different can also encourage the patient and provide hope for successful weight management. On the other hand, some people may need medical interventions such as pharmacotherapy to help them lose weight, but also help maintain that weight loss while on lifestyle therapy. We're simply treating them at a different point of their disease.
Despite obesity being a disease and despite national medical societies recommending a comprehensive approach to weight management that may also include medical intervention, in addition to lifestyle modification, pharmacotherapy, and bariatric surgery for appropriate patients, the utilization of these interventions remains alarmingly low. For example, approximately 3% of eligible U.S. adults with overweight or obesity were prescribed pharmacotherapy between 2009 and 2019, according to two large cohort studies. Similar trends are also observed for surgical interventions. A report published in 2018 by the American Society of Metabolic and Bariatric Surgery reported that less than 1% of patients in the U.S. who qualified for metabolic surgery underwent the procedure to treat severe obesity between 2011 and 2017. Lou, why might this be the case?
Well, Bob, there are a few reasons why clinicians are not prescribing weight loss drugs as often as they could. And some of these are topics that we all have touched on today. First, obesity is not universally recognized as a disease, so some clinicians may not feel comfortable prescribing medications for it. Second, many clinicians are not trained in the use of weight loss drugs. Third, there are competing priorities in a doctor's office, and weight loss may not always be top of mind when there are only 15 to 20 minutes to see a patient. Another reason is that weight loss drugs have a history of being perceived as less effective than they actually are. Some clinicians may also be concerned about the side effects of these drugs, which can include gastrointestinal effects, insomnia, among others. Ultimately, it's a combination of all of these factors that contributes to the underuse of weight loss drugs. It's a complex issue, and there's no easy solution.
I agree with Lou's points that all these factors contribute to the lack of urgency to treat obesity as a chronic disease. One of the biggest challenges is that patients often don't see obesity as a disease. They think that it's something that can be controlled by lifestyle changes alone. And even if they do see it as a disease, they may not believe that long-term medication is necessary. Patients may be reluctant to take medication for a long period of time. They may think that they can just take it for a few months to lose weight and then stop. But the reality is that obesity is a chronic condition, and medication may be necessary for long-term weight management. I like your analogy to blood pressure medication. Just like you wouldn't stop taking blood pressure medication after your blood pressure has normalized, you shouldn't stop taking weight loss medication after you've lost weight. Medication can help you reach a new weight plateau, but you'll need to keep taking it to maintain that weight loss.
Sometimes, even after accepting obesity as a disease and recognizing obesity management needs to be prioritized, a dialogue with your patients about their weight can be difficult. How do you approach this with your patients? Can you give us an example?
We're very big on education in our practice and helping people understand why they are struggling to manage their weight. I see a lot of successful people in my practice who are struggling with weight management. They believe that something is wrong with them because our society tells us that it's easy to lose weight. But it's not all their fault. It's something physical that's happened. We have to reiterate the key fact that obesity is a disease. It's not something that people can control just by willpower. We also have to educate clinicians about obesity so that they don't blame their patients, the same way they don't blame patients for having hypertension or diabetes. The acceptance of obesity as a disease is starting to change from the top down. Now, when I go to these big meetings, there's usually at least one talk on obesity. This is a good sign, but we still have a long way to go. We need to continue to educate people about obesity as a disease and to break down the stigma associated with it.
I think the starting point for the conversation is to get to know your patient and understand where they're coming from. You need to find out what their concerns are about their weight and what they're hoping to achieve by talking to you. It's important to be respectful of your patient's cultural background and body image preferences. Everyone has their own definition of what their weight should be, and it's important to be open-minded and understanding. It's also important to leave your own biases at the door. Even if you're an obesity medicine specialist, you still have your own biases. Be willing to put your patient's needs first and be patient-centric.
We've covered a lot of important topics, from the epidemiology of obesity to its genetic and environmental causes to why it's the most common non-communicable disease. We've also talked about how to bring up obesity with patients and the role of comprehensive weight management. I'd like to turn to both you, Lou and Jamie, now to summarize some of the key takeaways that you would like our listeners to know.
I think it's an exciting time to be involved in the field of obesity medicine. We're in a new era of how we treat obesity as a disease. In the past, We used to treat all the metabolic diseases associated with obesity, like type 2 diabetes and heart disease, but we didn't really focus on treating obesity itself. But now we're starting to realize that if we can manage obesity, we can often improve or even reverse some of these other diseases. So I think we're going to see more and more people getting involved in the field of obesity medicine. It's a growing field. There's a lot of opportunity to make a difference in people's lives.
Lou, I agree that this is indeed an exciting time in our field. Patients are now starting to expect that they can be successful with treatment in ways that have been difficult to achieve previously. If we as healthcare professionals can work to fight bias and stigma and maintain a patient-centric approach to engaging our patients with obesity, the experience of helping patients successfully manage their weight will be very rewarding all around.
This concludes this episode of Obesity, a Choice or a Disease. Please join us for the next episode of Obesity Chronicles, A Novel Perspective. For more information, please visit rethinkobesity.com.